In this particular section, we are going to discuss on the basics of acute leukemia. We have subsequent videos on acute myelogenous and acute lymphoblastic leukemia as well, but this video is really important because it tells you how to differentiate between acute leukemia and a chronic leukemia and how to differentiate between a myeloblast and lymphoblast through your staining as well as through your immunohistochemistry and CD markers. And also clinical features wise, we are going to differentiate between AML and ALL as an overall thing. So that's why this gives you a bird's eye view of what an acute leukemia is. So that's why this video is going to be of a real importance. Clear? The first one, you have to know what you mean by an acute leukemia. The moment you call it as leukemia, it's going to be increasing the number of your cells that are produced in the bone marrow. So that's what we call it as leukemia, which means the cells are going to be increased in number either in the bone marrow or in the peripheral blood or both. Clear? Not predominantly in the lymph node. That's the reason why in acute leukemia, the lymphadenopathy, hepatosplenomegaly is not that common, to be honest, in acute leukemias. The moment you call leukemia means the cells are typically seen in the blood and the bone marrow, not sequestered within the lymph nodes. If it's predominantly sequestered in the lymph nodes than the blood and the bone marrow, we call it as a lymphoma. We saw the differentiation already. So leukemia, you know that. So especially when you call this as an acute leukemia, there is going to be increase in the number of blasts in the bone marrow. Typically, by definition, it should be 20% or more in the bone marrow. But there are some small disclaimers in that which we'll discuss in some time. But anyway, increase in the number of blasts in the bone marrow is the one that is going to contribute to something called a definition of an acute leukemia. First of all, to understand the basics of why you develop a leukemia, there are certain hematopoietic progenitor cells. You have hematopoietic progenitor or precursor cells. And the function of this hematopoietic progenitor or precursor cells is to differentiate into subsequent lineages. For example, if you see a granulocyte monocyte precursor, it has differentiated into a granulocytic precursor and a monocytic precursor. The monocytic precursor has to differentiate into monocytes, and the granulocytic precursor further differentiate into neutrophils, eosinophils, and basophils. Those are the granulocytes. That is the basics. If suppose your hematopoietic progenitor cells are failing to differentiate, they have failed to differentiate, which means they have failed to differentiate, these hematopoietic progenitor cells will increase, and these are the ones that are contributing to the blast that you see in the bone marrow. And these blasts typically increase in number in the bone marrow, but later on they are going to spill into the peripheral blood as well, which means you are going to see this blast in the peripheral blood also. And within the bone marrow, these blasts, because they infiltrate, these are not functional, these are just blasts, immature cells. They infiltrate the bone marrow, they proliferate in number, and they are going to reduce the proliferation of other normal lineage cells, which means they are also going to result in severe cytopenias that also you will see in the peripheral blood. Which means in the peripheral blood, you are not going to get any functional cells like neutrophils, RBs or platelets. Instead, you will be getting only the blasts that are going to be spilled in the bone marrow. So this is the basic of a leukemia. At the same time, this proliferation of the blasts are typically going to be clonal proliferation. Clear? Clonal proliferation. It's a clonal malignancy because it originates always. Cancer is like that. It originates single cell theory. It originates from a single cell. That's what a cancer is all about. Which means most of the cancers, this leukemias also tends to be clonal proliferation of progenitor cells. Clear? So this is what you mean by an acute leukemia. Now comes the very important thing, that how to differentiate between an acute leukemia, that is an acute myelogenous leukemia, from an acute lymphoblastic leukemia. So among these two, which is more common if you ask me? AML tends to be the most common. That is acute myelogenous leukemia tends to be the more common, number 1 point. At the same time, epidemiology wise, AML is typically common in the 7th decade, especially around 68 years. This is the average age. But I'm not telling it will happen at 68 years only, but very common in the 7th decade. ALL is typically bimodal in distribution, which means they can be seen in the first decade very commonly, that is one peak, and very elderly patients also are affected. Extremes of age you can remember. But obviously the classic hallmark of ALL is happening in the first decade, And typically, the most common age group, if somebody asks you, I'm going to tell it's the 3 to 7 years of age. In fact, almost 80% of the acute lymphoblastic leukemias happen within 6 years of age, first 6 years of life. So ALL is very common in children. Clear? About the clinical features, AML tends to produce certain special clinical features and specific clinical features, and ALL tends to produce the same specific clinical features. So what are the special clinical features of AML? AML, the first one is going to be something called a leukostasis. That is due to extremely high blast count. These blasts going to, increase the viscosity of the blood, and they're going to, cause slow movement and sluggish movement of the blood, which means the blood that is coming prior to this sluggish flow will be, it will be staying there, and they're going to produce a stasis of the blood, which means the stasis because of leukocytosis is what we call as leukostasis because of WBCs. So typically they're going to present like hyperviscosity features like shortness of breath, chest X-ray infiltrates, even worst case scenarios hemoptysis, blurring of vision, TIA, stroke, type 1 respiratory failure. All these things are common whenever the patient is suffering from a leukostasis, and usually typically happens when the blast count is more than 50,000 in the peripheral blood. That's a very common scenario. That time only it happens. The next thing is DIC. It's the one thing that stands out from AML, stands out on behalf of AML compared to ALL. And this DIC is going to be very common in one particular type of AML called as AML M3, all according to the FAM classification, and which is also referred to as something called APL, otherwise called as acute promyelocytic leukemia. The next thing, you can develop something called a chloroma. Chloroma is again one thing that stands apart for acute myelogenous leukemia. So what do you mean by chloroma? Chloroma is nothing but an extramedullary collection of the blasts. Extramedullary collection of these blasts are leukemic cells outside the bone marrow, which means, so if they ask you, if they call you extramedullary collection of this blasts, you also have to know which is the most common site for this extramedullary collection, and I'm going to tell it's the skin which is going to be the most common site for extramedullary collection. It can also happen in gingiva, it can also happen in the lungs, it can also happen in the periorbital tissue, it can also happen in the brain parenchyma, and it can happen in many other areas. It's not like it's going to happen only in these areas which I'm mentioning, but skin is supposed to be the most common if this chloroma specifically happens in the skin, and that is going to be called as by a specific term referred to as something called a leukemia cutis. Clear? Remember, where in skin, that too very commonly in the skin of the extremities, in the limb skin, in the extremities of, the skin of the extremities only is going to be very commonly affected in leukemia cutis. Leukemia cutis is a subset of chloroma only. Chloroma is a general term given to any extramedullary collection of this blast. And what are the things that are going to increase the risk of this chloroma? I didn't tell you one more thing, that chloromas are also called as something called a granulocytic sarcoma, are also referred to as something called a myeloblastoma. These are the other names for chloromas. But there are certain things that increase the risk factor for chloromas. 3 AMLs. One is called AML M4, second is AML M5, and third one is, I can tell, AML M2. These are things. But especially those AMLs which are going to have your monocytic differentiation. Because this M4 and M5 we'll discuss in AML topic, where you can see clearly M4 and M5 are something going to have monocytic differentiation, especially when the AML tends to have monocytic differentiation. Those are the AMLs that are going to have a high risk of developing a chloroma in the first place. Then, this AML M4 is associated with certain cytogenetic change. For example, you have something called an inversion 16, that is a very common entity in AML M4. This inversion 16 is the very important risk factor for developing a chloroma or a granulocytic sarcoma. Similarly, in AML M2, you will see very commonly something called translocation 821, and this T821 is also going to be associated with a very high risk of developing a chloroma. So which means these cytogenetic abnormalities underlying the blast production also can be associated with a very high risk of developing a chloroma. In fact, I would suggest, rather than the type of AML that determines the chloromas, I will tell you the cytogenetics are the ones that determine the type of AML in fact, and hence the cytogenetics are the ones that are going to determine your presence of chloroma or not. So the cytogenetics are going to be the future, and cytogenetics are the most important in any aspect of hematopoietic malignancy, if you see. Now, and if you take a biopsy, for example, certain CD markers itself is going to have a high risk of chloroma. CD13 positivity and CD14 positivity itself is going to have a high risk of developing a chloroma. And similarly, when you take a chloroma biopsy, when you take this biopsy from a chloroma, you know very well it's very common in monocytic lineage, which means you're going to see monocytes within this chloroma. And you are going to see not a usual monocyte, they are going to be modified monocytes inside a chloroma very commonly, because I told you chloromas itself is very common from monocytic differentiation of, types of AML where you have monocytic differentiation. So obviously you are going to see mostly the monocytes within this chloromas. These monocytes, since they are abnormal monocytes, there will be something called a modified monocytes, and this is what we refer to as something called Arbiscoff cells. These are modified monocytes that you see within the chloroma. So these are some of the important points about understanding a chloroma. And next thing you want to see is the ALL. ALL, where you have bony pain or lumbar pain, very common because of infiltration of these cells into the bone. So typically lumbar pain, very common in these patients with AML. I told you in general lymphadenopathy, hepatosplenomegaly is quite not common in case of acute leukemia, but lymphadenopathy and hepatosplenomegaly is relatively common. I am not telling always present, but relatively common in case of a case of an acute lymphoblastic leukemia. But if they ask you in acute myelogenous leukemia, can you see lymphadenopathy, hepatosplenomegaly? Yes, lymphadenopathy, hepatosplenomegaly is common typically in AML M4 and M5. It can happen in AML M4 M5. Relatively common, I am not telling always, relatively common in these two subsets of AML. And then SVC syndrome, because many times they can produce huge mediastinal masses, which often results in SVC syndrome. Again, it's due to lymphadenopathy. SVC syndrome is a common feature of ALL. And CNS involvement happens in 10%. Again, it stands out in ALL compared to that of the AML, where you can develop cranial neuropathy, nausea, vomiting, raised intracranial pressure, a lot of stuff. And tumor lysis syndrome. Again, tumor lysis syndrome can happen in both AML as well as ALL, but I think it is relatively more common with ALL than AML. So these are the two important things that you have to see. But some common things are there. For example, you have something called cytopenias, which will not tell you whether it's an AML or an ALL, because it can happen in both AML as well as ALL. For example, you might get anemia, which can result in a clinical feature causing fatigue. It can result in a neutropenia, which can result in a clinical feature of recurrent infections. You can, can also result in thrombocytopenia, where you can get a clinical feature of severe bleeding also. So these are the cytopenias, and it is relatively common in both AML as well as ALL. That is the nature of this leukemia. So they reduce the proliferation of the normally produced normal lineages within the bone marrow. Clear? So that cannot differentiate. So these are some of the differentiating points, between AML and ALL. Then there are some investigations that you have to know. Investigations wise, you have something called a peripheral smear. In peripheral smear, what I am going to look for is the cytopenias, and it's going to be the blasts. That is what I am going to look out for. Blast. In peripheral smear, this is the one that is going to contribute more than 95%. This is not a criteria, but in general, in an acute leukemia, 95% or more of the circulating cells in the peripheral smear are going to be blast. So that stands out apart in an acute leukemia. So it's blast, and blast all the way. Plus, you can see certain blasts containing oil rods, and whenever a blast contains an oil rod, it is a single most important sign that is suggesting of an AML rather than an ALL, which we'll see subsequently in some time. Oil rods always tells you it's AML, not going to be ALL by any chance. Clear? So then you can do some other investigations like peripheral smear flow cytometry or immunohistochemistry, both of which we are going to identify the CD markers, which it's going to tell that it's a myeloid or a lymphoid lineage, and it can tell you a specific type of AML as well. For example, there are certain immunophenotypes that you can tell in flow cytometry. For example, what will be the features of myeloid lineage and what are going to be the features of the lymphoid lineage. lymphoid lineage. Typically, there are certain markers which I will tell you, but before that, in the myeloid itself, you have a lot of other types like monocytic differentiation, erythrocytic differentiation, megakaryocytic differentiation. All these things are going to come from a common myeloid progenitor cell only, which you'll see in the acute myeloid leukemia, which you have already seen in the previous topic in the basics of hematology. Now let us see what is the CD marker of a precursor cell. It's going to be CD34, it's going to be CD45, and they can be TDT positive and HLA-DR positive also. These are going to be the precursor cell markers. And there are certain markers of a proper myeloid lineage. This is nothing but CD13 and 33. These two I feel they are very, very important. Next important is the CD117. Then you have something called the CD15, and probably you can have something called the cytoplasmic myeloperoxidase. That's called CMPO. This is also very important myeloid lineage marker. And then you have a monocytic differentiation. You have CD11B, CD11C. I feel this 11C is the most important for monocytes. CD11B, 11C, and CD14, CD64, and CD15 in presence of lysozyme also. All these things. But as far as I know, the CD11C is going to be the most important for your exams for monocytic differentiation. Then in the myeloid lineage itself, you have something called erythroid differentiation. Erythroid differentiation typically has the CD71 and CD235A. The CD235A is also referred to as something called glycophorin A. These are very, very important markers of erythroid lineage differentiation. Then you have megakaryocytic differentiation. Megakaryocytic differentiation typically shows two markers, that is CD41 and CD61. This will be positive if it's a megakaryocytic blast. Clear? So these are really, really, really important for understanding, because this is the one that's going to tell you, like everything in the future. So lymphoid, markers, if it's a B neoplasm, B-based acute lymphoblastic, B-cell based acute lymphoblastic leukemia, it's going to have CD19 universal marker, CD20 and CD10 positive. Remember, CD10 is one thing that is universally positive in all ALLs. That's why initially it was called as, but later on we found out it was seen in many other cells as well, but it is seen in many, many ALL cells. This is what we refer to as common ALL antigen, CALA. So we know that already. In fact, this CALA is a very important marker, because whenever you have a CALA positive ALL, that indicates a good prognosis also. If you have a CALA negative ALL, it's going to have not good prognosis. That's why you can't tell poor also, but it's not a good prognostic ALL. The CD10 is a very important thing, even for prognostication, which I'm going to tell in the ALL once again. So then they might have this other B lymphoid markers like CD22, cytoplasmic CD79A. All these things are possible because these are blasts, not the mature lymphocytes. So blast means it's going to precursor cell, which is going to happen in the bone marrow. Second, you have something called T lymphoid markers. You know what are the T lymphoid markers? You have T cell ALLs also, that you have to identify using these markers. Like for example, it's CD3, CD5, CD7, CD2, CD1A, CD4, CD8, all these things are going to be T lymphoid markers. In that, the most important is the CD3, which is a pan T cell marker. Then you have natural killer markers. Two things, that is CD16 and CD56, out of which I told you multiple times the CD56 is the one that's going to be most important. Natural killer cell marker. CD16 are natural killers. We know the mnemonic already. So these are the flow cytometric and immunohistochemistry findings that you're going to see, which are really, really important for understanding. Which lineage of cells you're dealing with and what's the differentiation and subtyping the AML. These things are really important, paramount importance. Clear? Then you can do your cytochemistry also. In cytochemistry also you can make a differentiation. How will you differentiate between AML and ALL in cytochemistry? So how you are going to differentiate? In cytochemistry, let us see how to differentiate between AML and ALL. Myeloperoxidase, yes, very important. It's definitely a marker of AML. Then you have the Sudan black. Once again, AML not seen in ALL. Then you have PAS, AML also can be seen, ALL also can be seen, but remember only one type of AML gives this past positivity, that is erythroblastic leukemia, that is AML M6, which is of erythroblastic type. So usually what you will see, what type of staining you will see here is something called fine blocks, that's what you will see. Whereas if you see in ALL, you are going to see a coarse and granular staining. So this is what we call it as block positivity or coarse positivity, granular positivity. So what you see in AML M6 is a fine block-like positivity, where if you see in ALL, it's the same pass, it will be present, but it will be seeing a coarse granular positivity. So this is one important difference. And similarly, you have something called NSE, that's called non-specific esterase. Non-specific esterase can be seen in AML, but generally not a marker of ALL, but not seen in all cases of AML, but typically it is seen in AML M4 and M5, which means of monocytic differentiation. This non-specific esterase is very important marker for monocytic differentiated AMLs. Then you have something called an acid phosphatase. Acid phosphatase typically you will see in both AML and ALL, but in AML, as usual, only one particular type of AML, that is going to be AML M6, is going to have a acid phosphatase positivity, whereas here only one type of ALL, that is T cell ALL, will have acid phosphatase positivity, and they are going to have Golgi staining. Only the Golgi will be stained here. Here in AML M6 you will have a diffuse staining. Clear? So these are different, but both can show positivity for acid phosphatase and specific subtypes. But remember, every point is important. All these things have been asked in exams repeatedly for many times. That's why the cytochemistry carries a huge importance for exam sake. And we have not discussed about the bone marrow. Clear? And we have not discussed about the bone marrow. Remember, typically bone marrow aspiration or bone marrow biopsy is a must. Typically we do aspiration only, we don't do biopsy unless until you get a dry tab. But bone marrow aspiration is a very quintessential part of your AML investigations. So when you do a bone marrow aspiration, you are going to see at least minimum of 20% blasts in the bone marrow, and the bone marrow is going to be hypercellular marrow. Clear? Hypercellular marrow. When there are more than equal to 20% blasts in the bone marrow, is it really an important thing? Is it really, like you have to have 20% blast to diagnose AML or ALL? Actually, answer is no, not always. Not always. AML can be diagnosed with less than 20% blasts also, but they should have certain cytogenetic changes. That is why cytogenetics come into play, because certain cytogenetic changes are so characteristic of AML. If it's present itself, you can tell it's an AML, regardless of the blast count. Even if it's, like you see only 5% of the blast, it's not possible. But for understanding and substantiating the fact I'm telling this, even if you see 5% of the blast, if you see the cytogenetic changes which I'm going to tell now, it is AML regardless of the blast count, how much ever blast you see. What are the things? Number one, the first one is T1517, typical of acute promyelocytic leukemia, that's called T translocation 1517. Then you have translocation 821. Then you have inversion 16, we saw that already in M4. 821 we saw in M2 already. Then you have translocation 1616. All these things are enough to diagnose AML regardless of the blast count. If these changes are present in the blast, you do not need exact blast count. Even if it is less than 20, still these cytogenetic changes, if it's present, I'm going to diagnose this patient as an AML only, regardless of the blast count. Very important point. Again, that's why this cytogenetics is really important, because the moment you take for bone marrow aspiration, you don't only send for histopathological examination, you're also going to send for cytogenetics, which is very important. At the same time, I'm also going to send for flow cytometry, which is again really important. All these things are very important in these patients. Clear? Because especially the cytogenetics is what I'll tell you, because this is going to be the future for sure. There's no doubt about that. And final investigation you can say is on the lumbar puncture, whether really lumbar puncture is there needed or not, CSF analysis and lumbar puncture. Typically lumbar puncture we don't do for diagnostic testing. Instead we use this lumbar puncture for therapy, especially we call it as something called intrathecal therapy, especially for ALL. in ALL you need to give this intrathecal therapy because the brain and the CNS is supposed to be called as something called a sanctuary site for ALL, which means the CSF seeding is so common in ALL, so that the brain secondaries are extremely common in acute lymphoblastic leukemia, which you'll see there in ALL when you're discussing. That's the reason why intrathecal therapy is really important for like ALL patients. In AML patients, it's not given in all the patients, but instead in AML we'll give only for patients who's going to have this CNS symptoms. But anyway, lumbar puncture can be done in any patient with CNS symptoms and leukemia on the background. Especially you can do prophylactically itself in case of an ALL where CNS is regarded as the sanctuary site. So this is a very short video compared to the standards, but still it's going to tell a huge lot of information, a lot of basics we have understood. We can see right from the epidemiology to the clinical features to the immunophenotyping to the cytochemistry to the bone marrow examination and some little bit of the cytogenetics I've told you. So all these things are very important for exams, and this single video has a lot of MCQs than any other video which I've delivered. So please go through this very carefully, and with this we can conclude this short topic on basics of leukemia, and with this we can move on to the next topic. It's a big one, that is called an acute myelogenous leukemia.